Now, after doing the big topic of leukemia, let's talk about lymphomas in children. This lymphoma is a third most common, childhood malignancy when we look at the incidence, okay, and prevalence of cancers in children all over the world. The most common is leukemia, second brain tumor, okay, and third is lymphoma. Because this belongs to the hematology, so I'm doing it here. Now see there how we proceed further in this important topic. We start with the case history, talk about epidemiology, how common it is, which are the age group that are commonly affected, what is the male-female ratio, something like that. And we enter into the non-Hodgkin's lymphoma and then Hodgkin's lymphoma. Now see here, this is the way the child will present in case of lymphoma. This is a 3-year-old male child presented with neck swelling for 3-month duration. So what is the chief complaint? It's neck swelling for 3-month duration. There's no other complaints from the parents. There is no history of tuberculosis exposure in the past. Now, this is specifically mentioned here because tuberculosis commonly causes neck swelling or cervical lymphadenopathy. With treatment also, this is treatment, swelling not reducing in size. This is a significant history. Probably some antibiotics were prescribed for the child, but swelling is not decreasing even after that. On examination, cervical lymphadenopathy is present bilaterally, means on both sides. There is bilateral axillary lymph nodes also. And apart from them, there are no other physical findings. So what is the important examination finding here? Cervical lymphadenopathy and axillary lymphadenopathy. Let's see what other features this child has. On investigation, okay, during investigation, the hemoglobin was 8 g/cent. So what is the interpretation? Hemoglobin 8 g means what? What is this?
Anemic.
Anemia.
Exactly. This is moderate anemia. Okay. This is moderate anemia. Severe anemia means hemoglobin should be less than 7. So this is moderate anemia. WBC 10,000. This is within normal range. And platelet is 100,000. So it is slightly reduced. But we are not too worried for this value, because till platelet is decreased than 50,000, the chance of hemorrhage is not usually seen. ESR is slightly high, that is 25. Chest X-ray looks normal here. Mantoux test is negative. This Mantoux test is done for tuberculosis. You all know that. Okay, this is a screening test for tuberculosis or tuberculosis exposure in the past or tuberculosis infection in the past. It is negative here. Uric acid and LDH are normal. Now, these uric acid and LDH are routinely done in a case of malignancy just to see the tumor burden. If there are excessive tumor cells or if there is a massive type of organomegaly, then uric acid and LDH both would be high. Okay, but the normal value doesn't rule out malignancy. Remember that. Ultrasound of the abdomen is also normal. So they have decided for lymph node biopsy, and lymph node biopsy showed Reed-Sternberg cells with lymphocytic predominance. So Reed-Sternberg cell or RS cell with lymphocyte predominance variety is seen in the lymph node biopsy. So that almost cleans the diagnosis here. This is a case of Hodgkin's lymphoma because Reed-Sternberg cells are hallmark of Hodgkin's lymphoma. Okay. For the staging, they have also done bone marrow aspiration and biopsy, which are normal. That means bone marrow is not infiltrated by those lymphoma cells. So this is how you can reach to the diagnosis, and these are the different investigation. Very straightforward case, but sometimes it may not be that simple. And this is how the histopathology slide looks like. These are the lymphocytic predominance. These blue dot-like structures are the lymphocytes. And this owl eye appearance is the Reed-Sternberg cell. This is known as owl eye appearance. See that? Okay, this is a type of giant cell, Reed-Sternberg cell. Now with this, let's enter into the topic. Lymphomas result from malignant proliferation of cells of lymphocytic or histiocytic lineage, usually of lymphocytic lineage. But even histocytic lineage can, comes under lymphoma term. So malignant proliferation of cells of lymphocytic or histiocytic lineage. This is the third most common group of cancers in children after ALL and brain tumor. Out of this, 60% are NHL and 40% are HL. NHL means non-Hodgkin's lymphoma and HL means Hodgkin's lymphoma. Hodgkin's lymphoma is also known as Hodgkin's disease in some of the textbook. It's the same term, So majority of them are NHL. Hospital-based data often shows reverse trend though. Now this is a bit of contradictory sentences. This the third and the fourth, but let me explain this. Why? Still hospital data shows Hodgkin's lymphoma is more common than non-Hodgkin's lymphoma, because Hodgkin's lymphoma child commonly presents to the hospital. Non-Hodgkin's lymphoma child, that is the disease, advanced disease from the very beginning. So probably before coming to the hospital, these children, they die, so the presentation is late. And if they do not come to the hospital, how do we document that this is the diagnosis? That's why the hospital-based data shows some other way. Now, this is a very important slide. So I want my students to focus here, please. Take a bit of time here. Among all cancers, now see this, the childhood cancers is a very, very less percentage out of the adults. This circle, okay, look at this, 0.5% of the total malignancies only occurs in children. All others occurs in adult, especially the older one. Now, among these childhood cancers, now these are the common one. Okay, these are the common one. Now let me, highlight the important one: leukemias, brain and spinal cord tumors. Okay, brain and spinal cord tumors, and the lymphomas. So they are the quite common one. Okay, they are the quite common one. You can just remember like that. Then these other constitute so many other important types of childhood cancers which we discussed before, like neuroblastoma, Wilms tumor, retinoblastoma, hepatoblastoma, okay, rhabdomyosarcoma. All others comes here. Don't need to remember this exact percentage here. Now let's start with non-Hodgkin's lymphoma. Lymphoma constitute around 10 to 15% of all pediatric cancers. Okay, and according to how common are they, it belongs to third in the range. NHL or non-Hodgkin's lymphoma occurs in 60% of the lymphoma case. Male to female ratio is 3:1. So it is more common in the male child. 3:1, almost 3 times. Peak incidence occurs between 7 to 11 years of age. These are epidemiological data, Now, one very important point is there is a striking, geographical differences in the incidence rate and distribution of subtype of non-Hodgkin's lymphoma. Like a subtype is known as Burkitt lymphoma. This Burkitt lymphoma is very common near the equatorial region of the world. Okay, we know there is an equator, a line called equator, exactly at the center part of the earth, isn't it? Now, the countries which are near to that equator, they have done the researches, and it has been found that the Burkitt lymphoma, which is a type of non-Hodgkin's lymphoma, is very commonly found there. Okay, so this is a geographical variation of non-Hodgkin's lymphoma in different part of the world. Now, what is the cause? Epstein-Barr virus is almost invariably associated with Burkitt lymphoma. Epstein-Barr virus, never forget this. This is the causative agent of Burkitt's lymphoma. So even this virus is associated with Hodgkin's lymphoma cells as well. Now, what is the another malignancy caused by Epstein-Barr virus? Anyone? Any other name you remember?
Kissing disease.
This is a bit of difficult
Kissing
question.
disease, nasopharyngitis.
Mononucleosis.
Okay,
Infectious mouse.
but these are the diseases, not cancer.
Infectious mononucleosis.
Okay, good answer, but these are the diseases. So if the teacher asks, what are the other conditions caused by Epstein-Barr virus? Your answer is absolutely correct, okay? But what is another malignancy caused by Epstein-Barr virus? Now, Cushing's disease or infectious mononucleosis is not a malignancy. It is an infection. So the answer is
Gastric carcinoma.
nasopharyngeal carcinoma. Nasopharyngeal carcinoma. You can write it there. This is an important question in the exam. Gastric carcinoma is caused by one bacteria known as Helicobacter pylori. Epstein-Barr virus is not mentioned there. Okay. Now let's move on. There is an increased risk with immunosuppressive condition. Now see here, especially if there is cell-mediated immunodeficiency disorder or T-cell deficiency, there is higher chance of occurrence of non-Hodgkin's lymphoma. Congenital immunodeficiency syndrome like ataxia telangiectasia and Wiskott-Aldrich syndrome are commonly associated with non-Hodgkin's lymphoma. These are congenitally immunodeficiency disorders. Ataxia telangiectasia, okay, it runs in the family. It's autosomal recessive disorder. Ataxia means unable to walk on a straight line. So cerebellum is affected there, or the balance system of our brain is affected. And telangiectasia means dilated superficial blood vessels on the skin. Okay, I'm just explaining the meaning of this, but it is not that simple. It is an immunodeficiency condition. And Wiskott-Aldrich syndrome, okay, you have already studied before. Acquired immunodeficiency syndrome, AIDS, and post-transplant situation, they are also immunosuppressive conditions. So there is a higher chance of a non-Hodgkin's lymphoma, and any immunosuppressive drug therapy, if given for a long time, patient may develop lymphoma as well. The cases have been reported. Now let's classify NHL. They are low grade, intermediate grade, and high grade lesion. Low grade, intermediate grade, and high grade. But 90% of the children who present to the hospital with non-Hodgkin's lymphoma already have high grade disease. So even though there are 3 terms mentioned, most commonly this disease is a high grade disease. Okay. So this high grade non-Hodgkin's lymphoma is again further subdivided into different terms. These are large cell lymphoma, lymphoblastic lymphoma, which is usually T-cell type, and small cell non-cleaved lymphoma. Okay, these are usually B cell. Among them, there is Burkitt type and non-Burkitt type. So these are a little bit difficult type of classification in the beginning, but you need to repeat them. These are sometimes commonly asked question in the Viva exam. High grade non-Hodgkin's lymphoma can be of 3 types: large cell lymphoblastic lymphoma, which is usually T cell, and small cell non-cleaved lymphoma. This is the appearance of the cell. That's why the term has been given, non-cleaved lymphoma. Burkitt and non-Burkitts are the type. Now, let's enter into the important part of this lecture. How non-Hodgkin's lymphoma present? What are the clinical features? How we diagnose these children? The presenting symptoms are variable and depend upon the location of the tumor, extent of the disease, and histological subtype. Definitely. Where is the tumor? Is it in the head and neck? Is it in the mediastinum? Or is it in the abdomen? Accordingly, different clinical features would be there. How extent, the disease has been spread? Like, what is the staging of the disease? Is it localized to one area, or it is already spread everywhere? And according to the histological subtype, like large cell lymphoblastic type or small cell non-cleave lymphoma, the symptoms and signs depend on those. The children usually present with extranodal disease involving the mediastinum, abdomen, or head and neck region. So these are the three main sites for non-Hodgkin's lymphoma presentation. And extranodal means they quickly go out of the lymphatic system. So lymph node are part of our lymphatic system, So these malignancy, they quickly go out and involve some other extranodal site. That's why they are high-grade lesion from the very beginning. Now let's elaborate one by one. What happens if head and neck is affected in case of non-Hodgkin's lymphoma? So this occurs in almost 29% of the case, head and neck. HNN is head and neck, okay? In 29% of the case, and they may present as a cervical lymphadenopathy, enlargement of the cervical lymph node. Salivary gland, larynx, sinuses, orbit, and scalp can also be affected. Now see there, these are the organs which do not belong to lymphatic system. So they are also affected in case of non-Hodgkin's lymphoma. So salivary gland. So what are the types of salivary gland? Can you tell the names?
sublingual gland, submaxillary gland, and parotid gland.
Yes, sir.
Very good. Parotid, submandibular. Okay, it is called submandibular and sublingual. Excellent. Parotid, submandibular, and sublingual. Among them, parotid glands are the largest one. These are salivary gland. Now, paranasal sinuses. This sinuses means paranasal sinuses, like frontal sinus, maxillary sinus, ethmoid sinus, and sphenoid sinus. Other things are quite easy for you. Endemic Burkitt lymphoma will be presented as a jaw mass in 50% of the cases. Endemic is the term we use if some disease occurring in that area throughout the year or throughout the season. This is called endemicity. The disease is, found at that particular area. So that area is equatorial country. We already talked about that. So endemic Burkitt lymphoma may present as a big jaw mass, especially in the lower jaw of the face. Whenever you open any good surgical textbook like Bailey and Love textbook of surgery, and when you open that topic of Burkitt lymphoma, you will see a child who is having big jaw mass. That's how the disease may be presented. But Burkitt lymphoma doesn't only present as a jaw mass, okay? It may present as some other masses as well. Now, Walder's ring may be affected. Now, what do you mean by this Walder's ring? So let me explain this now. Walder's ring means this is a constellation of tonsil in the head and neck area. Tonsils are the collection of lymphoid follicle. So they are 4 in number. Okay, these are the tonsillar group in the head and neck area. Among them, the biggest one are called palatine tonsil. Palatine tonsils. These are the normal tonsils which we examine all the time in the child. Palatine tonsil. Another one is called lingual tonsil. Lingual on the back side of the tongue. Lingual tonsil. Third one is called tubal tonsil. Tubal, that is near the opening of eustachian tube or auditory tube. So where eustachian or auditory tube opens? Where? Anybody?
Sir, the middle ear to the nasopharynx connection.
Excellent. Very good answer. Middle ear to the nasopharynx. Very good. So when it opens in the nasopharynx, at the opening area of that eustachian tube, there is tubal tonsil present. Tonsil means, let me remind you again, it is a collection of lymphoid follicle. And the last one is called adenoid, and that is known as nasopharyngeal tonsil. Okay, nasopharyngeal tonsil. I'm giving you a little bit more knowledge here because this is important, anatomical information. So palatine tonsil, lingual tonsil, tubal tonsil, and nasopharyngeal tonsil, they are present as a ring-like structure in the head and neck area. These are called Walder's ring. So non-Hodgkin's lymphoma may affect them because lymphoma is a disease of a lymphatic system. So how it presents? The child presents as an asymmetric tonsil. On one side, the tonsil looks bigger than the other. So the examiner should think about why only one tonsil is enlarged here. Why not the other one? And usually the child doesn't complain of pain. So painless enlargement of the tonsil on one side, which is known as asymmetrical tonsillar enlargement, may be a presentation of non-Hodgkin's lymphoma. So biopsy has to be taken. Another one is the associated symptom like fever, night sweats, and weight loss, which are less common than in Hodgkin's lymphoma, but they may occur in some of the child. So this is about the head and neck presentation. Now, what happens if the non-Hodgkin's lymphoma occurs in mediastinum? Okay, you all know mediastinum means the area which is present between the two pleural cavities, or between the two lungs, you can say roughly. That mediastinum is involved in 25% of the case. Now, what happens if mediastinum is affected? There may be a large anterior mediastinal mass that can cause superior vena cava syndrome. It may be present in the anterior mediastinum or superior mediastinum, which may compress the superior vena cava. Now, students have already answered me what is superior vena cava syndrome. It may give pressure to the superior vena cava, so the head and neck area and the upper limbs area are, congested with blood. It can involve bone marrow and develop meningeal and gonadal involvement as well because of the metastasis. Pleural and pericardial effusion are also commonly seen because they belong, to that area. So they may present as the pleural effusion and pericardial effusion. So we need to do a proper workup. What type of fluid is that? We need to aspirate that fluid and send to the lab. How many cells are there? What type of cells? We have to go for cytology as well. How much protein is there? How much sugar is there? So all type of tests should be done. So this is mediastinal involvement. The third one is the involvement of the abdomen. See there, abdominal involvement. This is the abdomen involvement, or abdomen is the primary site in almost 35% of the cases. So this is the most common one. Inside the abdomen, the ileocecal region, appendix, colon, and retroperitoneal regions are commonly affected. And it may present as a big mass there, or it may present with abdominal pain, vomiting, abdominal distension because of the mass formation or because of intestinal obstruction. We may palpate that mass. Sometimes it may present as intussusception. Okay, the proximal segment of the bowel is telescoping into the distal one, that is called intussusception. It may present as intestinal obstruction as well as ischemia. It may present as ascites, free fluid in the peritoneal cavity, or it may present as obstructive jaundice if it gives pressure to the common bile duct, or if the lymph nodes are enlarged in porta hepatis. So, porta hepatis, remember, there are lymph nodes present. If those lymph nodes are enlarged, they will give pressure to those hepatic duct which are coming out, and again a patient presents with obstructive jaundice, or they may present with organomegaly like hepatosplenomegaly. So these are the abdominal presentation. Sometimes it may present acutely as an emergency situation like spinal cord compression, and this is a surgical emergency because we need to decompress that mass, otherwise patient will lose the function of the lower limb. Even bowel and bladder can be incontinent in this case. Now let's move further. How to diagnose non-Hodgkin's lymphoma? See this is a evaluation which we follow. We start with history and physical exam. HNP is history and physical exam, followed by biopsy. Biopsy is the confirmation. Now, biopsy should be taken from the enlarged lymph node or any organ which is affected there. In this case, tonsils. So this is just one example. Tonsil may not be involved. If tonsils are affected, like asymmetrical tonsillar enlargement, then you can go for tonsillectomy. The whole tonsil is taken as a mass and sent to the lab. Lymph node biopsy is very important, tissue which is obtained and sent to the lab. Now, any type of these malignancy, we have to go for staging. And to do the staging, we need to do a lot of investigation. Staging means what is the extent of the malignancy spread, how far it has gone already out of the primary site. This is called staging. So to know the staging, we need to do blood study like CBC. If pancytopenia is already there, that means bone marrow is already affected, and this is a very advanced type of stage. Biochemistry tests like renal function test, blood urea nitrogen, serum creatinine, and even uric acid should be done. If kidneys are affected, they will be high, and uric acid is usually high because this is a type of malignancy which has increased tumor burden. Liver function test, serum electrolyte, and serum LDH are some other important tests we should do in this type of condition. One, to know whether those organs are affected or not. And second, before I start the treatment, I should know what is the status of those organs. What is the status of liver? What is the status of kidney? What is the electrolyte, level? I must do baseline investigation. Lumbar puncture to know whether central nervous system is involved or not. Bone marrow biopsy to know whether bone marrow is affected or not. Chest X-ray and CT chest are important type of investigation here for the staging to know whether mediastinum is involved or lungs are affected or mediastinal lymph nodes are affected. Ultrasound of the abdomen, CT abdomen and pelvis are important tests, and bone scan to know whether bones are involved or not. So these are all different investigation done for staging. Now, the final step is management. So how we manage this case. The principles of therapy in case of non-Hodgkin's lymphoma management is chemotherapy. Chemotherapy, and we can go for radiotherapy also. So multi-agent chemotherapy is the most important type of the treatment. It is directed to the stage and histological subtype of non-Hodgkin's lymphoma. This is called cornerstone of the treatment, means most important part. Surgery has got very limited role except for diagnosis. Now let me elaborate on this. What do you mean by this? For example, there is a intra-abdominal non-Hodgkin's lymphoma. Sometimes I need to open the abdomen, which is known as laparotomy, and I need to take the mass out. This is a diagnostic purpose. Though I have removed the whole mass, it may not help the patient that much because the disease may have already been metastasized out of that primary site. Irradiation or radiotherapy is of the primary site is usually restricted to the emergency situation like cord compression and cranial nerve palsy. So in comparison to the chemotherapy, radiotherapy is not that important here. But nevertheless, we do this type of therapy in case of acute emergency situation like spinal cord compression, because I like to decompress that mass. I like to destroy that mass so that the compression is relieved. Drug selection and duration is based on the stage and histological subtype, and usually these cells are very sensitive to chemotherapy. Now, what type of drugs we are going to use? Now, see this? These are called multi-agent chemotherapy. They are cyclophosphamide, doxorubicin, vincristine, prednisolone, with or without methotrexate. These are the name of different, chemotherapeutic agent or anti-cancer drug. This is radiotherapy. Okay, radiotherapy not routinely used. You don't need to know in detail of these things. Okay, these are some sort of advanced knowledge in the treatment of malignancies. These 6 cycles of COMP are used, or 3 cycles of COMP with 6 months of 6 mercaptopurine and methotrexate are used. Now, this O stands for oncovine. Okay, O stands for oncovine. Okay, this is another term for vincristine here. Now, this limited stage disease, we provide for 9 weeks treatment. Whereas advanced stage disease, we go for longer therapy, that is 2 to 8 months. 2 to 8 months. And advanced stage disease can be a B cell or T cell type. If there is a relapse after we complete the treatment, the patient will have poor prognosis, definitely. Relapse always has a poor prognosis, any type of malignancy. And the relapse usually occurs in first 6 to 12 months of treatment. Now, the more important part among all of them is survival at 5 years. So please pay attention and you know what type of malignancy is this. The overall stage 1 and 2 NHL has, 5-year survival rate is 85 to 95%, and overall stage 3 and stage 4 NHL has survival rate of 65 to 75% only at the 5-year. And usually these are non-Hodgkin's lymphoma present in the stage 3 and 4 stage, because they are considered as advanced disease from the very beginning. So prognosis is relatively poor in comparison to Hodgkin's lymphoma. When we talk about Hodgkin's lymphoma, we'll talk about the prognosis. It is near to 90% there. So in comparison, it is lesser here. But in stage 1 and 2, it is almost similar. Now, what are the complications of non-Hodgkin's lymphoma? See this? The complication arising from space-occupying nature of the tumor. Space-occupying nature of the tumor. Where the tumor is developing, it will give pressure there. That is called space-occupying nature, and it will lead to problem. Like superior vena cava syndrome, already talked about. Pericardial effusion. First, it may present as a mass, and that pericardium may be infiltrated by those tumor cells or cancer cell, and then there will be collection of the fluid. It may act as a small bowel obstruction. It may present as a gastric bleeding or even GI tract perforation, especially in the abdominal type of non-NHL. Sometimes, if the tumor burden is very high, then tumor lysis syndrome may also be there. It's the same type of explanation as in leukemia, so it's very similar. Because we are using the chemotherapeutic agent here also for the treatment, and if the tumor cells are too much, then they are quite rapidly killed, and all the contents will be liberated outside, resulting in tumor lysis syndrome. Now with this, okay, we have concluded non-Hodgkin's lymphoma. Let's start the discussion of Hodgkin's disease or Hodgkin's lymphoma, which is a bit related type of topic. And this is very easy for you to understand now. Hodgkin's disease or Hodgkin's lymphoma is less common than non-Hodgkin's lymphoma, 60 to 40%. It is more frequently in 15 to 20 year of the population, and 4% of them occur under 10 years of age. And regarding the male to female ratio, it is the same one, 3 to 1, just like non-Hodgkin's lymphoma. Regarding some of the etiology or the causes, it is also associated with Epstein-Barr virus infection. And in the developing country, it is reported to have occurred in young children frequently, okay, quite younger than 15 to 20 years as well. And many of them present to the hospital. So the hospital trained data shows that Hodgkin's lymphoma is more common than the non-Hodgkin's. But if we do the big study, the community-based study, then the opposite, trend is shown. Now, the important part here, what are the types of Hodgkin's disease or Hodgkin's lymphoma? They are nodular sclerosing, lymphocyte predominant, lymphocyte depletion, and mixed cellularity. Nodular sclerosing, lymphocyte predominant, mixed cellularity, and lymphocyte depleted. Now see that? So nodular sclerosing looks like this. See here, these are a little bit dense type of morphology. There are septation which can be seen, and it looks like a lymph node, which are separated by the fibrous septa. Okay, nodular sclerosing. These are formed inside the lymph node itself. Lymphocyte predominant has a high number of lymphocyte there. Mixed cellularity. Okay, there are lots of Reed-Sternberg cells we can clearly see here. The lacunar cells also present, and there are lymphocytes also there. And lymphocyte depleted, which is not shown here in the picture, very few lymphocytes are present. And this has got a poor prognosis. More number of cells are there, more radiosensitive the tumor is. Okay, less number of cells are there, less sensitive the tumor is. That's why lymphocyte depleted have the worst prognosis in this type or in this case. Let's move further. Now, regarding the types of Hodgkin's disease, see here, this Rye classification is used very commonly. So all these types which we are seeing now belongs to Rye classification. Now, we're talking about the different types of Hodgkin's lymphoma or Hodgkin's disease. The Rye classification is used for that purpose. So these are lymphocyte predominance, mixed cellularity, lymphocyte depletion, and nodular sclerosis. Among them, the nodular sclerosis is the most common type. Now see here, it is the most common variety. Almost 2/3 of the patient have nodular sclerosing type. Although lymphocyte predominant and mixed cellular disease are more common in children younger than 10 years. Even if you don't remember this particular sentence, it's okay, but try to remember nodular sclerosing is the most common type of Hodgkin's lymphoma. This is an important MCQ question in the exam. Now let's move further. Reed-Sternberg cells are the hallmark of Hodgkin's lymphoma. So please mute yourself. Yes. Right. Okay. Now, Reed-Sternberg cells are the hallmark of Hodgkin's lymphoma, but they are not pathognomonic. The pathognomonic feature means they're diagnostic feature of that particular disease. And these Reed-Sternberg cells are not pathognomonic of Hodgkin's lymphoma because they are present in some other cases also. Okay, they can be found in a reactive lymphoid hyperplasia. They are found in non-Hodgkin's lymphoma as well, and they are found, okay, in other conditions okay, like in Epstein-Barr virus infection also. These are important point. So if they ask you what are the conditions the Reed-Sternberg cells are seen, you can answer like that. Okay, you can answer they are the hallmark of Hodgkin's lymphoma, but they are also seen in non-Hodgkin's lymphoma, reactive lymphoid hyperplasia. That means this is reaction to any viral type of infection, non-lymphoid malignancy, and even in Epstein-Barr virus infection. Let's move on. Now, the important part is clinical feature, how this child presents. What is a common presentation in case of Hodgkin's lymphoma? They usually presents in the form of asymmetrical lymphadenopathy in 90% of the time. Asymmetrical means it doesn't look same on both sides of the body. For example, on left side, there are big lymph nodes enlarged, but on the right side, they may not be present. During palpation, they are firm and rubbery. This is the characteristic feature of the lymph node. They are firm and rubbery, and they are painless. Firm, rubbery, and painless. They are present mainly in the supraclavicular fossa, but they may be present in other part of the neck as well. And they are progressive in nature. Means day by day or week by week, they become bigger and bigger. This is the important feature. 60% have mediastinal disease at the time of diagnosis. Mediastinal disease means mediastinal lymph node enlargement, and that can be picked very easily by chest X-ray. During chest X-ray, we see mediastinal widening or presence of lymph node near the hilar area of the lung or on both sides of the trachea. And that's how we diagnose it. Spleen and livers are usually enlarged. So this is hepatosplenomegaly, and around 1/3 of the cases, okay, have presence of constitutional symptom. That means fever. Fever is a type of constitutional symptom. Night sweat, anorexia or loss of appetite, weakness, and weight loss, which is more than 10% of the body weight. This is called significant weight loss if it has occurred over a period of time. Usually, according to the textbook, it takes 6 month duration, okay, to call it significant weight loss if it is more than 10% of the body weight. But 6 months may be a longer duration for this type of illnesses. So if it is more than 10% of the body weight, that is considered significant here. One important point, between Hodgkin's lymphoma and non-Hodgkin's lymphoma, the constitutional symptoms are more common in a Hodgkin's lymphoma type. So what does that mean? If a child comes to the hospital with asymmetrical cervical lymphadenopathy, if they are painless, progressive, firm, and rubbery, and if the child is having fever, night sweat, and weight loss, I will definitely think about Hodgkin's lymphoma and do the necessary workup. Now, some of the important points. Any peripheral lymph node, now please pay attention, this is important practical information. Any peripheral lymph node 1 centimeter in size or more, if it doesn't show signs of regression after 6 weeks of observation, should be biopsied just to rule out lymphoma. And this is a very common presentation in a child. Children usually have lymphadenopathy. So, and most of those lymphadenopathy are related to the physiological development of the lymph node group. So what we do, if they are having some symptoms and sign, we treat them with antibiotics probably and go for the observation. The size should decrease after some time. If the size are still the same, if signs and symptoms do not disappear, then don't wait any longer, go for the biopsy. That is the meaning. Okay. Now, another point, biopsy should be taken from the central node as possible within a group of enlarged node, as the edge of the Hodgkin's lymphoma node often appear reactive. So there are groups of lymph nodes, for example, in one area, like in the neck. take the biopsy from the central node as far as possible. And there are some atypical presentation of Hodgkin's lymphoma. They are not routinely seen in all the child. Okay, and it is very difficult for us to explain why these atypical presentations occur. But these are the common question in the exam, like nephrotic syndrome. Now, let me ask this question: what is nephrotic syndrome, guys?
The nephrotic syndrome is like sir, when there is too much protein during lecture, which we we have very much proteinuria.
Okay, good. That is a good point you have mentioned. Anybody else? Any other student? Okay, now listen here. Nephrotic syndrome.
With hypertension.
Okay, now listen. Nephrotic syndrome is a syndrome which has four important features together. One is massive proteinuria, which you are telling me now. Second, hypoalbuminemia. Because of that massive proteinuria, there is hypoalbuminemia. Third, there is edema. And fourth, there is hyperlipidemia. Okay, so heavy proteinuria, hypoalbuminemia, edema or anasarca, and hyperlipidemia. These are the four features of nephrotic syndrome. Probably these Hodgkin's lymphoma cells damages the glomeruli of the nephron or the kidney, which is causing nephrotic syndrome here. Autoimmune hemolytic anemia is another atypical presentation. There is destruction of the red cells because of autoantibody presence. Dermatomyositis is a type of connective tissue disorder which may be associated here. Acute dysautonomia. See, this autonomic nervous system is not functioning properly. And then central pontine myelinolysis. This is a very serious disorder where pons is getting damaged. Okay, the pons, it's a part of brain stem is getting damaged. So these are some atypical type of presentation. Among them, the common question from the exam point of view is nephrotic syndrome. So they may give you a clinical scenario of nephrotic syndrome, and they may give you one clue to the Hodgkin's lymphoma, like Reed-Sternberg cell. So you may correlate these 2 points together and reach to the diagnosis. Now, how to approach to a case of Hodgkin's lymphoma? Now see this, any case of neck node mass could be so many things. Hodgkin's lymphoma is just one of the differential diagnoses of cervical lymphadenopathy. Even tuberculosis can present in the same way. Other malignancy can present in the same way. Viral infection can present in the same way. Drug reaction can present in the same way. Okay, so that neck node mass can also be some other soft tissue mass. It may be a mass coming from the muscle. It may be a mass coming out from the bone. It may be a mass which is made up of by some tissues or organs there. So our thinking should be very broad. Never think only lymph node constitute the neck node mass. Here. So neck node mass could be enlarged cervical node. It can be varicose node. This varicose node is a distant metastasis, especially this type of patient is having intra-abdominal malignancy, and through the thoracic duct, the malignant cells are ascending up, and left supraclavicular lymph node is enlarged, which is known as varicose node. Left supraclavicular lymph node enlargement as a result of intra-abdominal malignancy. Don't forget that, very, very important point. Also known as Troisier sign. Okay, Troisier sign. Extension of the chest mass. It can also present as a neck mass. Okay, extension of the chest mass, like some malignancy in the chest, which is coming up towards the neck. And it may be a local tissue origin other than lymph node, like a thyroid mass, for example. Okay, a thymus, which is enlarged and coming towards the neck. Any of those may be there. Now, what are the differential diagnoses of cervical lymphadenopathy? They may be malignant, okay, like leukemias, which may be ALL or AML. This is one of the common presentation of leukemia, lymph node enlargement. It may be juvenile myeloid leukemia or juvenile chronic myeloid leukemia. Remember, just now we discussed lymphadenopathy is a common feature in JCML. Hodgkin's disease, that's what we are learning right now. Non-Hodgkin's lymphoma can also present as a cervical lymphadenopathy. Neuroblastoma, this is the malignancy of sympathetic ganglia. Okay, the most common site is adrenal gland, but it may metastasize to the lymph node very easily. Rhabdomyosarcoma, RMS. Okay, rhabdomyosarcoma. This is another malignant, tumor which can metastasize to the lymph node. But what are the non-malignant causes of lymphadenopathy in the neck? Tuberculosis, okay, tops the list, very, very common in the developing world. And one of the commonest presentation is cervical lymphadenopathy. This is known as lymph node tuberculosis. Atypical mycobacteria, they specifically involve only the lymph node, but they may affect the lung also. It depends on which type we are talking about. Mycobacterium scrofulaceum, Mycobacterium kansasi, Mycobacterium marinum. These are the different types. HIV, okay, this is a virus which commonly causes lymphadenopathy. Reactive hyperplasia as a result of other viral infection. Cystic hygroma. Now, what is cystic hygroma? Anyone?
Collection of lymph in a cyst is called cystic hygroma.
Let me explain, sir.
Yeah, sure.
So basically, sir, like we have a connection between the smaller lymph channel and the larger lymph channel. Like, sir, if there is some sort of a disconnection between them, so sir, the fluid will collect in that area, and we call it cystic hygroma, sir.
Very good. Both of you are, clear in your concept. Very nice. This is a cyst which consists of lymph, and this lymph is collected there because there is no connection between the smaller lymphatic channel with the larger one. Means those smaller lymphatic channels are collecting the lymph in that local area, but it is not drained away from there. So it is collecting there, So this is usually a congenital situation, cystic hygroma. It is very commonly found in the neck. And Turner syndrome is a condition where cystic hygroma is very commonly found. This is an important point from the MCQ point of view. Turner syndrome and cystic hygroma. Now see that? So these may be the differential diagnosis. Even hemangioma can present in the same way. These are the tumors arising from the blood vessel. So what I'm saying here, okay, is the most common mass which is there in the neck definitely is a lymph node. There's no doubt. But sometimes other mass can also present, or some other disease can result in lymphadenopathy. So our thinking, our mind should be broad. Now, how to confirm the diagnosis? This evaluation is almost similar to the non-Hodgkin's lymphoma. See this? History and physical exam, chest X-ray and CT scan of the chest, CBC, ESR, evaluation of serum copper, alkaline phosphatase, TSH and T4. Now, some are a little bit different from the non-Hodgkin's lymphoma. So let me highlight them. One of them is serum copper. This is a condition where serum copper level is high. Okay, serum copper level is found high. Probably it is associated with the copper carrying protein that is called ceruloplasmin here. Alkaline phosphatase is high when they present as obstructive jaundice, because it leads to lymphadenopathy. If lymph nodes which are near to the porta hepatis are enlarged, they will give pressure to the common bile duct, and then it presents as obstructive jaundice. ALP level will be high. Another one, ALP is also high if there is some problem regarding the bone. If there is bony metastasis, let's say, and there is a destruction of the bone, as a result of that, some osteoblast will try to synthesize the new bone, and during that time, alkaline phosphatase may be high also. TSH and T4, this is an association. Okay, this is association. The patient may present as a hypothyroidism sometimes. So ultrasound or CT scan of the abdomen, spinal fluid analysis, LDH, serum uric acid, biochemical test, biopsy of the lymph node, and if we see Reed-Sternberg cells, our diagnosis would be almost there. Bone marrow biopsy, just to know whether bone marrow is affected or not. Gallium scan, also known as bone scan, and laparotomy. Okay, if our diagnosis is in doubt, if there is a intra-abdominal mass, we can go for laparotomy, but as far as possible, we do not go for it because it is highly invasive procedure. This is a big surgery itself. That's why it is written as a controversial here. Now, regarding Hodgkin's disease or Hodgkin's lymphoma, staging is an important part. You should know about the staging of Hodgkin's disease like this: stage 1 to stage 4. Stage 1 and stage 2 are known as the early diseases. Stage 3 and stage 4 are the advanced disease. So stage 1 means involvement of a single lymph node group. Okay, so here involvement of a single lymph node region or group, or a single extra lymphatic organ. This is known as 1E, E for extra lymphatic organ. Okay. Stage 2, involvement of 2 or more lymph node region on the same side of the diaphragm. That means axillary group of lymph node and cervical group of lymph node both are on the same side of the diaphragm. So it is stage 2. Or another part may be 1 lymph node region and 1 extra lymphatic organ, which should be on the same side of the diaphragm again. Maybe a parotid gland with cervical lymph node enlargement. So that is how I explain here. Stage 3, involvement of lymph node region on both sides of the diaphragm, means inguinal lymph node and axillary lymph node. Now they are on either side of the diaphragm. That is the meaning. Plus an extra lymphatic organ, the spleen, or both. All of them belong to stage 3. And stage 4 is the most advanced one, definitely. There is a diffuse involvement of 1 or more extra lymphatic organ, with or without lymph node involvement. Means it is metastasizing everywhere. Sometimes we add A and B after each of the stage, like stage 1A or stage 1B, stage 2A or stage 2B. What does that mean? A means no systemic symptom, like no fever, no night sweat, okay, no anorexia, and no weight loss. Whereas B means presence of constitutional symptom like these. So this is how we stage Hodgkin's lymphoma. Now we are reaching to the final part of this discussion: how to manage. Just know some of the basic stuff. Nobody is going to ask in detail regarding this. The localized disease, stage 1, 2, or even 3A can be managed by extended field radiotherapy. Radiotherapy are important part of the management here, whereas in non-Hodgkin's disease, radiotherapy are very rarely used. In case of disseminated disease like stage 3B and 4, we can go for this type of management, like nitrogen mustard, okay, oncovin or vincristine, procarbazine, and prednisolone. Procarbazine and prednisolone, these are different types of anti-cancer drug. Prednisolone is a type of steroid. Whereas ABBD, A stands for adriamycin, B is for bleomycin, B for vinblastine, and D for dacarbazine. Okay, so these are the drugs which we use for the treatment. Now let's move further. The management, regarding the management, radiation therapy can be used very exclusively here, but there are lots of there are lots of problems regarding the radiation therapy. In my previous lecture also I have talked about this. Radiation therapy can cause growth retardation by causing damage of the pituitary gland as well as thyroid gland. It can cause, some, problem regarding the heart function and the lung function, and in the long run, there is increased risk of breast cancer as well. So chemotherapy is preferred by many centers, though radiation therapy is still used in the targeted area, not like overall, but in the targeted area. Okay, chemotherapy is used exclusively, and if the relapse is there, we can go for additional chemotherapy or irradiation therapy or both. This much detail is not necessary for you. Now, what is the prognosis of Hodgkin's disease? Look at the survival rate. Stage 1, 2, and 3, the survival rate is 90%. It's always 5-year survival rate. In stage 4, it is dropping up to 80% to 75%. So still, it is better than non-Hodgkin's lymphoma. So it is a type of a childhood malignancy which has got good prognosis. At the end, okay, this slide is for you. I'm not going to discuss this in the class. This is how we compare Hodgkin's lymphoma and non-Hodgkin's lymphoma, and this is one of the common questions which we ask in the exam. Okay, with this, let me stop here for today.